Good morning. It's my pleasure to speak with you today. The title of my talk is called Mona Lisas and Mad Hatters, Vulvovaginal Atrophy in the Modern Era. I have no disclosures relevant to this talk. It turns out that Mona Lisas and Mad Hatters is an Elton John song. And this concept sort of for this talk came to me as I was discussing some of the new types of strategies for vulvovaginal atrophy, which we'll also refer to as GSM, or genital symptoms of menopause. And some of the strategies seemed a bit crazy, and some of the strategies have some pretty artistic names. But we're going to break it down today in 20 minutes. The objectives of our talk is to review the strategies for treatment of vulvovaginal atrophy. That includes lubricants, moisturizers, hormonal strategies, which includes estrogens, selective estrogen receptor modulators, or SERMs, non-estrogens, alternative therapies, medical devices, and we'll discuss the current scientific literature regarding CO2 laser for the treatment of vulvovaginal atrophy. Vulvovaginal atrophy is also termed the genitourinary symptom of menopause. This new terminology was published in 2013, and it introduces a collection of symptoms and signs associated with essentially a decrease in estrogen in the genital tissues. This involves changes to the labia, to the clitoris, to the vestibule, to the introitus, to the vagina itself, as well as to the urethra and bladder. And the symptoms that patients may have include dryness, burning, pain with penetration called dyspareunia, irritation, itching, or urinary symptoms like dysuria or urgency, or even frequent UTIs. Dryness is essentially caused by decreased vaginal lubrication, and there are many causes. Advancing age, hormonal changes, such as the loss of one's ovaries to cancer, menopause, whether natural or surgically induced, breastfeeding, stress, medical conditions such as diabetes, inflammatory bowel disease, chronic heart failure, multiple sclerosis, and other iatrogenic causes, meaning my fault, chemotherapy, anti-estrogen therapy, radiation therapy, and antidepressant use. Vulvovaginal atrophy, or genital syndrome of menopause, is a common and possibly underreported problem. In a very large study from the International Women's Health Study, postmenopausal women between the ages of 40 and 75 from the US and Europe were asked about their symptoms. The prevalence was 40 to 52% in that study. The lowest was in Germany and the highest was in Spain. In the UK, a survey of the same type of women, but only about 2,000 patients, demonstrated that 33% of women who reported vaginal dryness or dyspareunia said that they did not disclose this to a provider. And only 36% of patients sought over-the-counter remedies, with most patients saying that they just dealt with it on their own. There are a lot of strategies, and one of the most common is to use estrogen. If estrogen loss is the problem, we can replace it. And vaginal estrogen has been reviewed in many large-scale clinical trials. A large systemic review of vaginal estrogen preparations for this exact cause suggests that compared to placebo, vaginal estrogens are all effective treatment. Now, systemic estrogen absorption is something that's very controversial, especially when we're just trying to treat one part of the body. So systemic absorption of estrogen from the vaginal preparations is lowest with the 7.5 microgram ring, which is pictured above, or the 10 microgram tablet, which is pictured below. The highest systemic absorption comes from cream formulations, especially the larger dose creams of estradiol. But some patients have contraindications to estrogen. They simply can't take them. It's not safe. And those patients we think are hormone receptive positive breast cancer patients, so ER and PR positive breast cancer patients for whom their breast cancer is not eradicated. Endometrial cancer patients for whom their cancer has not been eradicated. Patients with active venous thromboembolism, so PEs, strokes, deep venous thromboses, and those patients we think estrogen is probably not safe. So there are ways to deliver medication to selectively activate estrogen within the body in some places and not in others. And those drugs are called SERMs, for selective estrogen receptor modulators. The one that's approved for use in the vagina is called ospemifene. And this is a 60 milligram oral daily medication. In the 2013 pivotal trial, there were 600 women with symptoms of pain with intercourse. secondary to vulvovaginal atrophy. And those patients that were treated with ospemifene versus placebo demonstrated improvement in both their perception of symptoms as well as documentable vaginal pH and maturation index seen on vaginal cytology. This is the largest study. This is, you can see from this graph here that all the patients self-reported vaginal dryness as a main symptom, and there were improvements in the ospemifene, which is in the darker bar, in maturation and pH index. And there was no significant increase in endometrial thickness as measured by ultrasound, which is consistent with the data that ospemifene really only works as an estrogen modulator in the vagina, but not in the endometrium. Now, all that's great, but sometimes all we can give a patient is lubricants versus moisturizers. And these are definitely the most common things that we use for the treatment of vulvovaginal atrophy. So vaginal moisturizers should be separated from vaginal lubricants. Vaginal moisturizers are designed for daily use. They're classified as a two-way medical device by the Medicines and Healthcare Regulatory Products Agency, as they are intended to be in the body for more than 60 minutes, but less than 30 days. So they're subject to an enormous amount of regulation about their formulation and their purity. Vaginal lubricants, which are provided only for short-term relief, are not subject to the same amount of scrutiny, but most of the providers of vaginal moisturizers also provide a sexual lubricant, and we'll go through several different brands. So what's the best lubricant? If you Google this, you will get a variety of scary things, including things that are for your car. It's very hard to determine from the internet what the best lubricant is. And a study that can help us is really what we need to turn to. So when we think about a vaginal moisturizer, what are we asking the study to guide us to? We want to know how the design of a vaginal moisturizer can help us. So in this specific case, we're looking for a moisturizer that's designed to rehydrate the mucosa, stick to the surface of the epithelium, and function like a normal vaginal secretion to eliminate the vaginal dryness and the daily sort of itching, burning dryness that patients experience. So the frequency of use is generally proportional to the symptoms. So the effect of the moisturizer can last up to 2 or 3 days, but if the patient needs to use it every day, it should be safe to do so. And then we want the pH of the vaginal moisturizer to augment a return to normal acidic pH somewhere around 4 to be enhanced. And what's in a vaginal moisturizer or lubricant, that's actually the same, but it should have water and polymers. Polymers are these long chains of carbons, and they're required for the water to stick to the surface of the vagina. An excipient, which I had to look up for this talk, it turns out is a substance formulated alongside the active ingredient of a medication. And it's included for the purpose of long-term stabilization, for bulking up solid formulations that contain potent active ingredients, or to confer a therapeutic advancement. In the sense of a vaginal moisturizer, the types of excipients that are used are generally to provide a specific feel on the hand. Often water plus polymer would be very, very liquid, and you wouldn't be able to like get it out of the tube and onto or into the vagina adequately. So the excipients are used to make a more cream-like substance. And as well, there needs to be a pH buffer. As we mentioned, pH is really important for restoring normal vaginal flora. So some commercially available vaginal moisturizers are listed here, and I certainly don't expect anyone to memorize them, but they have been analyzed for both their pH as well as their osmolality. We're going to talk about those two things really quickly. So pH, as we mentioned, is important, and estrogen contributes to the growth of lactobacillus and thus a normal decrease in pH in the vagina. As I mentioned, it's about 3.8 to 4.5. 4 is a good number to remember. Lactobacillus colonies decrease in menopause, and Enterobacteriaceae colonies increase. And so there's a complex microbiome that's happening, and these studies suggest that estrogen effect could be achieved with appropriate lactobacillus probiotic. But these studies have not borne any fruit because low-dose vaginal estrogen is still most effective, as well as just maintenance of pH. So osmolality is important because it is amount of solute dissolved in a solvent, which just means how much water compared to the solid bits, even if they're microscopic, that exist in a compound. Osmolality is important because osmolality determines the shift of water from one place to the other. The World Health Organization recommends that the osmolality of a personal lubricant not exceed 380 milliosms in order to minimize the risk of epithelial damage. Basically, if something is really, really concentrated and it's in the vagina, it may actually pull the water out of the vagina and damage the tissue. So most commercially available preparations greatly exceed this value, but the upper limit of what's considered acceptable and safe is about 1,200 milliosms per kilo. This is from a very large review by Edwards in the Climacteric, where he describes what milliosms are available in the commercially available vaginal moisturizers and lubricants. And I've highlighted them here for you at the bottom. And you can see that these bottom 10 or so meet the requirements. You'll notice that there's one brand in particular that keeps popping up here. That brand is called Yes. They make the most kinds of lubricants and moisturizers that meet the WHO requirements for milliosms. This is looking at pH. So remember, we wanted the pH to be between 3.8 and 4.2. So anywhere between, you can see these white bars, 4 to 4.5, and these are the lubricants and moisturizers that are included here. You'll see that there's 2 moisturizers, Silk Natural and Yes, that both meet the pH requirements. And then the rest of the lubricants in here are, there's Realtex, Yes, Higher Nature, Astroglide, and KY right up here at 4.5. And just so you don't think other people are being crazy, these are anal lubricants up here, and this is actually the normal pH for the rectum. So if those are the kinds of lubricants you're looking for, this brand is making the proper pH. So what do I recommend? For patients that have urogenital atrophy, elevated vaginal pH, and experiencing pain or dryness or discomfort in their daily life, we generally recommend a vaginal moisturizer with an acidic pH. So any of those that I mentioned could be used, and an osmolality below the WHO ideal recommendation of 380 milliosms per kilo. It turns out that there's really only one brand that meets both of the requirements. There are about 10 brands that meet just the pH requirement, and that's the brand Yes Vaginal Moisturizer. And it also does not have glycols or parabens, which some people may be allergic to. For vaginal lubricant recommendations, these are for sexual lubricants. So this is for pain with intercourse or penetration. We're looking for a vaginal lubricant with an acidic pH and an osmolality below the WHO recommendation of 380. In this case, there are 2 brands that meet both the pH and the milliosms, and that's the Yes water-based intimate lubricant, and then the Astroglide ultra-sensitive skin lubricant. The Astroglide meets the pH and is less than the 1200, which is the maximum, but doesn't go under 380. It's about 700. So alternative therapies. Everyone always asks me, isn't there something else I can do? So natural lubricants such as coconut oil and olive oil have no data, although there was a study of olive oil used in the Overcome study with 73% of patients finding it helpful at improving pain with intercourse. So it's definitely something that we can offer to our patients, and if they find that it's helpful, there's no harm. Isoflavones are plant-based estrogens. There are vaginal gel isoflavones that have been compared with no treatment in women with vulvovaginal atrophy, and those patients were treated with tablets. They were also given a vaginal gel with lactobacillus, lactic acid, and calendula, as well as isoflavones. An exam at 0, 2, and 4 weeks demonstrated improvement with the treatment per patient report. So that's another potential option, although this is not commercially available at the present time. Compounded suppositories. So you can find these in a lot of places. They generally include beeswax and coconut oil, calendula, and olive oil. Sometimes they'll have evening primrose oil, which has isoflavones in it, and cocoa butter. They come in beautiful little shapes and things, but they're not regulated by any agency. So there's no guarantee what's in them or where that ingredient came from. And so a user should be very cautious about these kinds of things because of the potential that there may be an ingredient that you don't want in there. So this was a very big news in 2014 when the FDA approved the Mona Lisa Touch laser for vaginal dryness caused by vaginal atrophy. And this is a very exciting new therapy, but it has some data missing, and we're going to go over what data is available to help us make a choice about this. So how does this work? So basically, this is a far infrared laser that delivers points into the surface of the vaginal epithelium. And I've written all of the rich science here for you, which I can totally explain if you're interested. But most people just want to know what really happens. And basically, the laser punches holes into the surface of the vagina, micro holes. Those micro holes cause tissue damage that then gets repaired, and new collagen is formed in the places where it was damaged. And that causes the vagina to become more resilient by activating new collagen instead of old collagen. It's very similar to what we do to our yards when they become thatched or too thick and the grass just doesn't grow and the lawn isn't flexible and soft. We get one of these pluggers out and we cause micro injury to our lawn. And then the grass grows in fresh and clean underneath that, has more space to do so. It's essentially the same thing. And it turns out that fractional CO2 lasers have been used in lots of aesthetic medical applications for the skin to have the effect of stimulating, producing new collagen and elastin and bolstering the extracellular matrix. This was originally developed for burns to help with the significant contractures that come with severe burns. And this technology was demonstrated to do that. So this remodeling is really exciting. This is what it looks like. This is the DECA brand version of the fractionated CO2 laser. And basically you can see that the laser comes out in tiny points. And then there's a reflecting mirror for circumferential coverage. So that reflecting mirror is going to rotate during the procedure. It takes about 12 weeks for fractional CO2 laser to be given. There are 3 applications over a period of 12 weeks. And then in this pilot study, which also has the same general mechanisms, there's pre and post vulvar vaginal symptoms were assessed using the Vaginal Health Index score and a QOL. In this study, there were 50 patients treated with a 12-week follow-up, and 84% reported satisfaction with the procedure with an improvement in their scores. In another study at a university hospital, they were looking to see if the 30 women treated with fractional CO2 laser system would experience any benefit. They did a baseline examination and then 3 months post-treatment. And women received in this schedule the same treatment, 3 weeks, 3 treatments, 6 weeks apart. They measured visual analog scales for vulvar vaginal symptoms and then the visual scale and the female sexual function index. There was also clinical measurements of vaginal calibration with dilators at baseline and after treatment. So basically what they saw was they had an average improvement in pain, burning, and itching of 1 or 2 points, but the significant improvement in dryness and pain with penetration. Very minimal improvement in the vaginal symptoms related to dysuria. In addition, they, as I mentioned, they did dilator studies and were able to demonstrate that for pre and post treatment, the patients definitely seemed to be able to tolerate a larger size dilator. And despite this data, remember there's only 30 patients in this study, there was significant uptake in the community, and a lot of people were bringing these laser devices into their offices, leading ACOG in May of 2016 to put out a position statement just to sort of remind folks that, that this is not a FDA-approved device. The technology is approved, but the device itself has not been approved or cleared by the FDA for the specific indication of treating vulvovaginal atrophy. So there was a call for more data, and the VELVET study was started. And this was to really give us data about comparing vaginal estrogen to vaginal laser therapy. The VELVET study was started in 2016. And it was very, very exciting. We were waiting for this to come out, and it did in January of 2020. So the VELVET trial was a multi-center randomized control trial of participants who are menopausal women who were experiencing significant vaginal dryness. And they excluded patients who had prolapse, recent pelvic surgery, prior mesh surgery, active genital infection, history of estrogen-sensitive malignancy. So there were no estrogen-sensitive cancers in this, or autoimmune conditions. Interestingly, they did not exclude people who had had prior HPV-positive PAPs, but they did not report this data either. They've then randomized them to fractionated CO2 laser, 3 treatments 6 weeks apart, or vaginal estrogen, which we know from our previous look into the data is very effective. And the primary outcome was vaginal dryness by visual analog scale. So it turns out that the enrollment had to close before the completion of the trial because the FDA required an investigational device exemption for laser therapy. It's called an IDE. And unfortunately, the authors chose to complete the treatment of enrolled patients and close the study because they did not have the ability to get an IDE. The company that makes the device refused to hold the IDE, meaning that they would have to submit the paperwork for it, and the investigators simply couldn't do it on their own. So they had planned to enroll about 120 patients. They enrolled 69 women, and 62 of them completed the 6-month protocol. And basically, on the primary outcome, they noted no difference in vaginal dryness scores or visual analog scale. There really wasn't much of a difference between the groups for these genital symptoms of menopause, vaginal burning, itching, and dysuria. They did note that the patients felt satisfied or very satisfied with both treatments. So between the laser group and the estrogen group, both groups felt that they were better than when they started. But comparing the groups together, there was no demonstration of improvement on either. So all we really know is that in this study, there was no significant difference between the two groups. And a larger study will really need to be done to tell us if one is better than the other. So what about patients with prior vaginal radiation? Can they undergo fractionated CO2 laser? We don't know. Patients with prior HPV infection or history of abnormal pap testing? We don't know. Patients with prior estrogen responsive tumors who can't use estrogen? We really don't know. However, in the 2016 SOCAL study, they do discuss that some patients referred for the pilot study were unable to use estrogens due to a history of estrogen responsive tumors. So we know, at least in the very initial 30-patient study, some of those patients likely had an estrogen responsive cancer, but we simply don't know what their long-term outcome was. A big issue of this is cost. It's an important factor to consider as this procedure is not covered by insurance. And currently that cost varies pretty widely between about $1,800 and $3,000 for 3 treatments. And we know that we need future investigations to understand the associated costs between continuous use of vaginal estrogen therapy and the costs associated with CO2 laser therapy over the same time period. It turns out that the SOCAL group also decided to do a cost-effective analysis, which actually just came out in December of 2020. They looked at, although there's no studies, they looked at the analysis of comparison of CO2 laser therapy alone versus oral ospemifene versus vaginal estrogen. And basically, they were able to see that all 3 treatments were found to be cost-effective below the willingness to pay threshold of $50,000 per quality adjusted life year. So they were all fairly cost-effective. However, if the cost of laser therapy was reduced to 20% of its current cost, it becomes the optimal strategy at adherence values above 29%, meaning that like in a 6-month course of treatment, if the laser only costs 20% of what it costs now, it would be significantly better for patients in terms of overall adherence to therapy, as well as what we believe the overall outcome would be. But if not, it's not cost effective if the adherence falls below 38.8%, meaning that if you don't get all 3 treatments, it's no longer cost effective. Patients falling off in terms of treatment does happen either due to cost or just due to discomfort with the treatment itself. So in conclusion, I just want to say that vulvovaginal atrophy is really common. Estrogen is an option for those without a history of estrogen-positive tumors or for patients for whom their tumor has been eradicated. And a lot of us feel that although there's no data, 5 to 10 years of no treatment for a cancer is probably sufficient time to believe that that cancer has been eradicated and that estrogen, especially in low-dose local forms, is probably safe. Alternatives to estrogen therapy exist with the SERMs. There are vaginal moisturizers and lubricants that can improve some symptoms, but caution should be used in which to try. And fractional CO2 laser of the vagina is an emerging technology with minimal data, but it's extremely exciting. We have some specific safety concerns for our special population, such as those patients with active HPV or prior radiation. And we look to our researchers to answer those questions in the future. We really, really want people to include patients with prior cancers who have lots of these symptoms who may really benefit from this treatment. Thank you very much.
Hi there. It's really an honor to present as part of the Alaska course. And I really want to thank my friends, Dr. Hardesty, as well as Dr. Hope for the invitation once more. I'm going to talk about sexual health and intimacy for you. In terms of conflicts of interest, I have none. And what we'll cover briefly is to show how common it is for cancer to impact both sex and intimacy, to describe the relationship between intimacy and intercourse and how it differs from male patients, and then to outline what is available for folks who have issues. So in terms of putting this with a very broad brush, sexual health issues is actually an incredibly common concern for people who are treated for cancer, for our patients like you treated for a gynecologic or pelvic malignancy. It ranges between 25 to 90%, and a lot of that depends on how you ask the question. For example, if I asked, how often do you have issues with intimacy, I will get one set of answers. But if I ask how often is intercourse painful, I might get a different set of responses. There has been some work to look at the incidence of sexual dysfunction outside of people who have had breast cancer. And this is important because much of the data we have has been generated through studies of volunteers who had breast cancer. There was this meta-analysis, it's now 4 years old. So essentially it was a review of all of the literature. And what they wanted was to find out how common sexual dysfunction was. They wanted to include studies with over 30 people within it. And for women, they used a very specific survey instrument called the Female Sexual Function Index, or the FSFI. And that was their only criteria to include it. And of greater than 1,000 articles that they looked at, they could only find 27 papers which addressed the prevalence or how common sexual dysfunction is as measured through the FSFI. And what they found that when you looked at these 20 plus papers, it also wasn't a survey across all cancer types. Indeed, they only looked at 4 cancer types, and probably that's an oversimplification, because if you look here, there were some studies on bladder, many studies on breast, colorectal, and then they lumped gynecological malignancies together and called the gynecologic cancers a cancer type, which we know is an oversimplification. However, all of these studies showed mean values of less than 20, showing all of these studies confirmed that at least half of patients included in this study had sexual dysfunction. Indeed, the lowest values weren't even in people who were treated with it for a pelvic cancer. It was for people treated for colorectal cancer. Now, when you look at the prevalence studies of sexual dysfunction, the estimate is anywhere between 35 to 94%. But among those studies that reported the prevalence, the highest prevalence was in gynecological cancers, and across studies, about 78% of people treated for gynecologic cancer had sexual dysfunction. And remember, when we talk about sexual dysfunction, we're actually talking about more than just the ability to participate in any singular activity like intercourse. what we're actually talking about is intimacy and sensuality. We're talking about body image and the experiences of arousal as well as desire, the experience of climax, and then that sense of sexual satisfaction. So, sexual health doesn't speak to any one activity. Sexual health goes beyond activity. That's a really important point. So here's a true or false question you can answer in the comforts of your own home. After a diagnosis of cancer, sexual health in men and women is impacted in a very similar way. The answer to that question is false. Cancer affects men and women very differently. This is the oversimplified version of male sexuality. When men are erect, that's when they tend to have desire and when they tend to crave intimacy. But when that switches off, if men are unable to have an erection or are not erect, then they tend not to be overtly concerned about intimacy and sexual function. In fact, it's the likelihood that they are more happy sitting in front of the TV watching a sports game when they don't have an erection. Female sexual health is actually very, very complicated. It is not as simple as desire. There is an intricate set of connections that govern female sexual health. And I like this idea of looking at it like a computer screen, because when one is healthy, when one is young, when one is in a partnered relationship that is sexually satisfying, all you need to do is feel like you're on, and everything works, everything plays, and everything goes well, and it's enjoyable. After cancer, those connections can all be disrupted, such that even when you feel amorous, nothing happens, or it takes a long time for something to happen, or the connections don't lead to pleasure. They actually might even lead to pain. And so all of this is highly confusing, much like when a computer breaks. When a computer breaks, none of us want to get underneath and try to figure it out ourselves. Most of us sit there with complete confusion, trying to understand why it's not working. And it can be exceptionally frustrating. And that is a very common human experience after cancer. So, what should you know about female sexual health after cancer? This is Rosemary Basson's model of female sexual health. I find it does speak to a lot of people who come see me in consultation. And essentially, it starts here in intimacy. When someone is growing up and developing, that sense of intimacy is what motivates the sexually neutral person to wanting to discover more. And that want of intimacy helps one discover that when their body is touched, that it's stimulating and leads to arousal. And this arousal then promotes desire. And when desire is satisfied, the circle propagates. Now, there is a bypass loop that is also described between stimuli and satisfaction, where it has nothing to do with intimacy. It's about the fulfillment of desire. But this is the model that seems to speak to a lot of people who are treated for cancer. And what you need to know is that every single one of these arrows is prone to being impacted by cancer treatment, whether that be the surgery you did, the chemotherapy administered, the radiation that you underwent, or even the targeted treatments you continue to be on. All of these areas can be impacted. And so it's not a simple pointing towards one factor that made things go, quote, wrong for you. Importantly as well in this model, which really stresses the psychosocial aspects of sexual health, female sexual health is not inherently dependent on an activity. So intercourse isn't here, self-stimulation isn't here. Desire can be satisfied by sexual activities or non-sexual activities. So if you ever looked at your partner and said, you know what I find really hot right now is if you were to do the dishes. That is explained through this model because the desire to satisfaction doesn't require intercourse. So in terms of the approach to treatment, I like to break this up. Vaginal health should be addressed. Vaginal dryness, menopausal symptoms should be addressed in its own right. But as a side benefit of addressing vaginal health, sexual health can also be addressed. And I know my colleague already presented on vaginal health, so let's talk about sexual health and what are the ways we can make sexual activities more pleasurable. Now, there is some interest in the use of testosterone because testosterone has been known to be a positive factor in the improvement of desire among postmenopausal women, women who have what was once referred to as hypoactive sexual desire disorder, which means that even though sex is enjoyable and they can have an orgasm and it can be satisfying, the feedback loop is broken so that they can also walk away from that and never want it again. There is a primary desire disorder. Testosterone plays a role in that. Even for people who had a hysterectomy with bilateral salpingo-oophorectomy, not for cancer. Testosterone can increase the frequency of sexual activity and increase pleasure. So why don't we prescribe it in people after cancer? It's because we don't know if there's an impact that justifies the risk of side effects. This was shown in a randomized clinical trial that was done by the North Central Clinical Trials Group. It included 150 postmenopausal women who had no evidence of disease, and it was a straightforward design of testosterone or placebo with a crossover effect at 4 weeks. What they showed was here, as measured by the Female Sexual Function Index, there was no change in sexual function with testosterone placebo either the first 4 weeks or after crossover into the second 4 weeks. Now, some criticism of this study might be the duration, that 4 weeks wasn't sufficient enough time to achieve a benefit with testosterone, and then it was further masked with the crossover. I think it's a legitimate question, but this is the randomized data that is here. We also don't know the profile of people who were treated on this study. My sense is that most of these patients had breast cancer. Another component for sexual activity and sexual pleasure is the use of a vaginal lubricant. Now, there are two variants of that. There's a water as well as silicone-based lubricants. There's no data on people after cancer as to which one works more effectively. There was this very interesting double-blind trial that included over 2,000 women that found no difference in either pleasure or satisfaction associated with one or the other lubricant. However, people who were practicing penile anal intercourse expressed a preference over water-based lubricant, but that was against no lubricant at all. Importantly is this one figure. When I talk about lubricants, know that I'm not talking about saliva. Saliva is not a lubricant. What about natural oils? Can you use coconut oil, olive oil as a lubricant? Many people would like to stay away from chemicals. There was one study, it's here, it was called Overcome. It was only 25 people, and it was a multimodality treatment of pelvic floor rehabilitation, a polycarbophilic-based vaginal moisturizer, as well as olive oil during sex. At 12 weeks, if you look at the last bullet here, 8 to 9 out of 10 people who use olive oil, 7 out of 10 people who use olive oil thought it was beneficial. Now, what's the reason not to use olive oil? There is some concern that it will go rancid in the vagina. So for the most part, those of us who practice or are in this field of sexual health do not recommend using olive oil or natural oils as an internal lubricant. So what about if you have pain with penetration? The technical term for that is dyspareunia. And there are two types. So if you are experiencing pain with penetration, it's very, very important that you have a physical examination. There can be pain at the entry point of the vagina called the vestibule, and that has a term. It's called vestibular tenderness. But even if you can enter or initial entry into the vagina is comfortable, there can be spasmodic pain with thrust. That term, which is a smooth muscle phenomenon that cannot be controlled, is called vaginismus. Again, for women complaining of pain, an exam is critical. If we find vestibular tenderness, there's actually a very nice treatment for that. Now, when I say that, it has to be absent vaginismus. So this is women who have pain with initial penetration, but not afterwards. So topical lidocaine was the subject of a randomized trial in breast cancer survivors. And it was compared against the placebo preparation. The way this topical lidocaine was prescribed, it was a watery lidocaine called aqueous lidocaine. It was a 4% strength, so exceptionally dilute. She instructed people to use a cotton swab, to saturate the cotton swab and apply it directly onto the vestibule for 3 minutes before planned penetration. Compared to placebo, this very simple maneuver lowered the pain scores at a month. And after open label use, where everyone was allowed, 9 out of 10 people experienced comfortable penetration, and 17 of 20 women who were abstinent due to this were able to have and resume penetrative intercourse. Importantly, we also learned this does not cause anesthesia to the male partner. If you have vaginismus, or that smooth muscle spasm, usually it's experienced with thrusting in the vaginal valve. The treatment for that are vaginal dilators. There are multiple types. The ones in the back, which look like candlesticks, are Syracuse dilators. These are more silicone-based with a head on it called the Biotech dilators. And the newer versions, you are able to control both length as well as girth. All of these are available. The important point to know is that it is very difficult to measure effect because there's a lot of people who just cannot do this on a routine way. My advice, if you are recommended to use a dilator for vaginismus, is to use it in the morning rather than the end of day. Usually, if you can make it part of your getting ready routine, you'll have more energy to do it versus later in the day when most people are very tired, because most people are multitaskers and the last thing they want to do is to further exercise, particularly within their vagina. There are drugs that are available now to treat both interest as well as arousal issues. However, I would say that most people who have had cancer don't have this as a primary issue, that the lack of interest and the lack of desire is due to changes in that Bassin model, either because you don't experience desire or arousal as you used to, you experience pain with penetrative intercourse, or you're not finding this satisfying. All three of those issues can dampen desire, okay? However, there are at least these drugs on the market for desire. Flibanserin is a pill that's taken daily. Its approval is in premenopausal women with low desire. There's no evidence after cancer. Bremelanotide is a subcutaneous injection that can be done 45 minutes before intercourse. It also is approved in premenopausal women. Unfortunately, no data that it has an impact on people with cancer. Testosterone, the negative trial we reviewed on, bupropion. This is an ongoing trial of this antidepressant to help improve sexual function in women. It's an ongoing randomized trial. The PDE5 inhibitors, which are used to treat erectile dysfunction, are not approved, and there's also no data to treat female sexual dysfunction. So, in conclusion, everyone deserves a sex life. That includes everyone that's listening to this talk. and it includes the young adult, the older patient. It includes patients in relationships, as well as patients without a partner. It includes LGBTQ patients, as well as those patients who have advanced or metastatic disease. And it, of course, includes the oncologist. And with that, I will close. Thank you so much for listening. And please remember, if you want it, you do deserve a satisfying sex life. Thank you.
Hi, I'm Leslie Boyd. I'm a gynecologic oncologist at NYU Langone in New York City. And I'm really honored to talk to you guys as part of Let Every Woman Know. We're going to talk about quality and time today. So first, an outline of the talk. I'm going to talk a little bit about definitions, what we mean by quality and time. Talk a lot about patient-reported outcomes. These are important metrics to look at in terms of quality. We're going to talk about how we should prioritize outcomes and from some good research looked at from survivors. Talk a little bit about palliative care and what that means in terms of overall quality and how that impacts on survival. We'll talk a little bit about how to individualize these decisions for you. So, definitions. So it seems like it's fairly straightforward, but just to be clear, when we're talking about time, we're talking about length of life or survival. There are lots of different ways to determine this. A few that we usually use in terms of cancer, one is progression-free survival. So from the time of starting a treatment to the time and hopefully we get to a remission where the disease goes away. But how long does it take before the disease comes back, if it comes back? So it's really time alive without disease. We also look at how long do you live after the diagnosis or treatment, and that determination can be done just for the disease itself. So how long does it take for the cancer to end to death? Or how long does it take for death by any cause to happen? When we're talking about quality, quality is a big umbrella statement when we're literally talking about quality of life. And there are lots of different ways we can look at that. Performance status is a metric that physicians apply to their patients based on how functional they are. So functionality is a big part of quality, meaning how much time of the day do you spend out of bed, how many of your usual activities are you able to do. But personal goals can also be a function of quality. Are you able to do the activities that you enjoy? And maintenance of relationships, are you able to spend time with friends and family the way that you would like to? Both of these are assessed, most importantly, by clinical trials, although those are not the only way that they're assessed, certainly. So patient-reported outcomes have become a really important way that we determine quality. They're a very important part now of large randomized or phase 3 clinical trials. There are many different ways that we use to look at this, many surveys which have been validated. And what happens here is that we're able to compare, for patients who are on two different comparing arms in a trial, how does the toxicity of the treatment or how does their well-being overall change between the two arms, between the two medications usually? So this is something that we look forward to seeing in larger clinical trials, but that we may not often see in single arm or phase 2 trials. So here's just a set of examples of the different kind of surveys that are available. There are some that are just general, just overall well-being. Some are cancer specific, so there are some for endometrial and cervix cancer, for example. Some relate to your sexuality and your sexual health. Others are specific to particular symptoms. So there can be several on fatigue or pain or neurotoxicity. Emotional well-being is another area of specific surveys. And then cancer distress, relationships, and decisional measures are all separate areas as well. And this is only a summary. There are more than this, certainly. So when we look at patient-reported outcomes, intuitively, we assume that looking at them will be helpful in terms of monitoring quality of life and how our treatment impacts on quality of life. But this important study was reported in 2008, so some time ago now. And what it did was it took a series of large clinical trials, all of which had significant patient-reported outcomes as part of the trial. And 39 trials met the criteria for having rigorous enough patient-reported outcomes. And they looked to see, well, how did the patient-reported outcomes fare in terms of assessing how patients did? And it turns out that in the vast majority of the trials, which were not related, 36 out of 39 trials, the patient-reported outcomes were significant predictors for the patient's survival. So if you did better from the standpoint of your patient-reported outcomes, you were likely to live longer. So the global measures were the most helpful. So that's quality of life and overall physical functioning. But other symptom measures were also helpful in different trials. And another interesting fact, if you looked at how the physicians did in terms of predicting survival, really with performance status, which is a measure that we give to our patients, the patient's own report was more instructive in terms of survival than the physician's estimation. So why did this work? There's multiple theories. One, maybe these are better indicators of overall functioning well-being than the indicators that we're using, for example, performance status. They may be picking up earlier clues and changes than other measures. And also, better scores may be linked to better behavior. So perhaps if your overall outlook is better, you're more likely to exercise. So that's going to impact how you do overall. And some of these scores may reflect coping skills with the disease process, meaning if you are coping well enough to maintain your quality of life, perhaps that has an impact on how you do from a cancer perspective. That's quite speculative. So what does this mean? What should we be doing about it? Well, it does mean that patient-reported outcomes should be used more often as part of routine clinical practice. Perhaps we should be thinking about grouping patients within clinical trials by their patient-reported outcomes data, right? So those who are the most functional would be in a different group than those who are less so. Maybe we should be looking at ways to improve patient-reported outcomes. So if we can enhance someone's well-being, will that then lead to an improvement in survival overall? And if these are so helpful for patients with cancer, should we be looking outside of cancer patients to other patients and seeing if we can bring this information to them to help patients with other chronic severe diseases? So this is a very common survey called the FACT G7+1. I'm showing this one in particular because it is very commonly used, very well validated, and it is very short. So many of these measures are quite lengthy, 20 to 30 questions. They take at least a half hour to implement and are not really helpful in a busy clinical setting. But this 8-question survey, really in easy to understand language, really gets to the heart of how a patient is doing remarkably quickly. And I think is a great way to start using these in routine clinical practice, not just for a clinical trial, but for every clinical visit. So I'm going to give an example of how patient-reported outcomes are particularly helpful for me as a clinician, and that is when I'm thinking about patients going on maintenance therapy. And the example I'm going to use here is PARP inhibitor therapy. So PARP inhibitors have become a really important part of ovarian cancer treatment. As you may know, they're very successful drugs, but the results of their results really depend on whether or not you have a BRCA mutation or if your tumor has BRCA-like properties. I'm not going to get too much into that here. But briefly, this trial, there are several FDA-approved PARP inhibitors. I happened to pull the data from the large niraparib trial. So this is data on niraparib. This is data for patients who have had a first recurrence and who have platinum-sensitive disease, and after their initial treatment go on maintenance therapy. So this is therapy not to get rid of the disease, but to maintain their current state, which is usually without disease. And if you have a BRCA mutation, well, taking this drug is a slam dunk. We look at, this is progression-free survival. So at the 50th percentile, if you have the BRCA mutation, about 50% of people at 6 months are going to have the disease come back. But if you take the niraparib, we're extending that a tremendous amount of time, way out to here. So of course, that's an easy decision. If you have a BRCA1 mutation, you're going to want to take niraparib. The decision's harder to make when you don't have a mutation, because there's definitely a statistical improvement here, but it's a much shorter duration. So if this is a drug that you're taking to keep disease away, when you currently don't have disease, how much toxicity are you willing to take to be on this drug for, in this case, around a 4-month improvement? Thankfully, patient-reported outcomes can help us make that decision. So here, this slide is awfully busy, but I will summarize it for you. There was a lot of patient-reported outcomes built into that trial, looking at overall functional measures as well as some symptom measures. And really, in all of these, just as a quick summary, the only area where there was a concern with the niraparib compared to placebo was nausea. So this is the niraparib, here's the placebo, and you can see the niraparib more nausea than the placebo. But if you looked at all of the others, actually here the placebo has higher toxicity than the niraparib, and all of the others really very close changes. And so, and in the global quality of life, which I don't show here, no statistical difference, and really not thought to be a clinical difference. So that helps me to tell my patients that quality of life is not going to decline significantly while on this drug. And I think it's important for patients to ask for this kind of information when they're considering new therapies, and certainly new maintenance therapies, to make sure that they're not changing they're not substituting significant toxicity, particularly in situations where benefit may be small. So it's one thing what I think, but I think more importantly, what do survivors think about this? And thankfully there have been some really nice data from this. This is actually from our group at NYU with Dr. Frey and Dr. Blank, talked to members of the group SHARE through surveys and through interview format to see what toxicity, what side effects were they willing to undergo throughout their continuum of care. When they polled everyone, interestingly, the majority of patients said, well, the most important thing to them was additional life, so survival. But close behind was the ability to engage in daily activities. And so what was particularly interesting was that for any given symptom, the interest or the willingness to tolerate that symptom depended on what was the goal of care. So if the goal is cure, and that's in navy here, you're almost always willing to accept worse symptoms than if the goal is just to keep the disease at bay, stable disease. And so you can see that for every single disease or toxic or side effect, that going for cure makes you more likely to accept that problem compared to just stable disease alone, which I think intuitively makes sense. So another study was done with a different group asking the Ovarian Cancer National Alliance similarly, and I'm not going to go through this data too closely, but similar findings insofar as depending on where you were in your disease continuum, you were more likely to accept higher toxicity if the goal was for cure than not. So now I want to spend a little bit of time talking about palliative care. Palliative care is an important umbrella term that can mean a lot of different things. So, and certainly it varies by institution, but what we hope for out of palliative care is that this is a important conjunctive treatment group that's available to all patients who have severe chronic conditions, certainly not just patients with cancer, and that is multidisciplinary. So what that means is it's not just physicians, that there are often nurses, advanced practice nurses as well, social workers, chaplains, physical therapists, all of whom are trying to help patients with their symptoms and with their well-being. So it's a more holistic look at the patient, and not just their physical well-being, certainly emotional well-being, and their contextual well-being, I say, which means kind of how they are doing for themselves and for their community. Hospice is part of palliative care, but palliative care is not hospice, which is to say that I have many patients who are anxious when I bring up palliative care because they think I'm bringing up hospice care. Hospice relates really very specifically to planning for the end of life, and we have designated that as six months, what we think is 6 months left to live. Palliative care is part of hospice, right? So you enter hospice with palliative care intent, but certainly palliative care can be initiated far earlier than that. And it's not just the end of life, can encompass far more. So there's a really important paper back in 2010 looking at palliative care and its impact on patients. And this group actually looked at patients with non-small cell lung cancer. And unfortunately, these patients at the time of diagnosis, and certainly back in 2010, had about a year to live in general. And so this group said to their medical oncologists, now when you meet a new patient, we're going to randomize these patients either to immediate palliative care or to standard care, where where the doctor, the treating physician, initiates palliative care when they're ready or when they think it's appropriate. The patients in the intervention group, in the earlier care group, had to start with the palliative care team within 8 weeks. So then they looked at how patients did based on which group they were assigned to. And not surprisingly, when you look at the functional outcomes or the patient-reported outcomes, the patients who had early palliative care scored higher than the patients who got standard care. I think that makes sense, right? So if you have a group that's looking towards your emotional well-being, then you're likely to do better there. Same thing for kind of functional as well as mood symptoms. I think what was not expected was that the patients in the palliative care group who were randomized, who therefore were not different than the other group, lived longer. And those patients who got early palliative care got less chemotherapy than the patients who were in standard care. And even with the less chemotherapy, lived longer. And the thinking of that is that, again, helping the whole person probably has impacts beyond the disease that we don't exactly understand, and may also avoid very toxic chemotherapy at the end of life, which will extend life. This was a kind of groundbreaking paper that established this, but it's not the only paper, and several others followed. There's another paper published in 2009. This one was not powered to identify a survival difference, so it's not statistically significant, but then they went on to do another evaluation. This one is statistically significant, so that the patients with early palliative care lived longer than those with delayed care. So I certainly think about this when I talk to patients about the role of palliative care, and I encourage them not to think of this as hospice care, not necessarily to think about this as limiting their survival, but to broadening their overall health and possibly extending their survival. So one thing I want to touch on very briefly, how do we talk about quality in the face of cancer, particularly in the face of a life-threatening cancer diagnosis? How do we help patients, and how do patients themselves navigate the difficulty of this? So going from, oftentimes my patients go from feeling like healthy individuals to having this incredibly challenging, physical, threatening situation, which can lead to fear, anger, shame. And how do we move forward from this? And I think making meaning out of this diagnosis is something that many physicians see. I see in my patients all of the time, and is why I think my patients are some of the most incredible and brave women I know. This is an image of the Buddha and a quote ascribed to the Buddha, although I think it's paraphrased, which is, "Pain is inevitable, suffering is optional." So how do you come to terms with your diagnosis? How do you make meaning of your life in regard to the diagnosis and in a larger view? And we think as clinicians that your ability to do this certainly impacts how well you cope going further and with the disease as well. And briefly, there is a whole field of research on this called post-traumatic growth that doesn't only deal with cancer, but this particular study happened to. And this study showed that those individuals who were able to make meaning, were able to have better peace scores, and basically came up with a metric to determine how peaceful you were. And that depending on, no matter what life events came, because this is the thing with cancer, is that of course you have the underlying cancer, but you also have a pandemic, you have unemployment, you have teenagers, you have all of these stressors in your life. So how do you deal with all of those things together? And the more meaning making you have in whatever mechanism that is, the better you're going to do with all of it, the cancer and whatever life throws at you. So what's the right balance? Of course, there's no right answer for everyone. So much of this is going to be individual choice, talking to your family, to your community, taking in your religious beliefs and spirituality, and figuring out what goals that you have. From a physician perspective, it's clear to me that being honest, empathetic, and listening, that's my job, to give as much clear and concise information I can, and then to listen and to hear what my patient needs. And perhaps understanding from both of us that it's going to change, just like we said before. Prognoses change, expectations change, life changes us. And so to have this long dialogue over time is perhaps the most important. Thank you so much for your attention. It's been such a pleasure to talk to you today.
Dr. Boyd and Dr. Dizon for those absolutely fantastic talks. We have some questions that are coming through, and if you have more questions, those who are listening, please feel free to put them into the questions and answers icon down at the bottom of your screen. Dr. Boyd, Leslie, since you just spoke, I wanted to just address a question towards you. How do you think we do as G1 oncologists in talking about end-of-life considerations with our patients as a whole?
Hi, Joni. Again, thanks for having me. It's been really wonderful. You know, that's tough to say. I think some of the data suggests that we as physicians are not so great at it. You know, in general, we're pretty bad at estimating when the end of life is. There's a lot of data that shows that. And since we can't estimate when it is, we often have the conversations too late. That said, I think G1 oncologists, we're really blessed. Many of us do the surgery and the chemotherapy. So as a result, we have these really long relationships with our patients. I think we prize a great deal. And so having that long relationship, I do think makes it easier to have these difficult conversations because we know our patients, we know their families, we know all of the travails they've gone through for so many years. And so even though in some ways it's heartbreaking to have to say these things to patients who have really become our friends, it's best for us to be the ones to be breaking that news.
And so, corollary to that, at what point in the cancer care journey do you generally initiate conversations with your patients about end-of-life planning and that question of time and quality?
So it's certainly an individual, I make individual choices. I will say that there are some patients and some diagnoses who I have palliative care working with them almost from day one, because I know the prognosis is poor and that symptom control will be problematic. And so it's really important to get them involved right away. Other patients and other diagnoses, I know the arc is much longer and the ability to control symptoms is easier. And it certainly depends on the patient and family, but as soon as I think about it, I think I try to initiate it. I think in general, we tend to bring these things up too late, if anything.
Dr. Dizon, what do you think about that? You had to unmute, I believe.
Yeah. So I would agree with Leslie on that. I think we oftentimes really try to hold out hope, and we really try to be optimistic. And it's a journey that we take with every single person that we're treating. And to think that we're not engaged or not invested would be a lie, because we're invested in all of our patients really doing well. We've been prompted through the development of electronic medical records. And certainly here at Brown, we're using something called the VIA pathways. And one of the questions that is embedded in that is something that came up from work in Boston. And we're asked a question about, would you be surprised if your patient died in the next 6 months? And if you answer yes, there's some data that suggests if you wouldn't be surprised, that actually predicts patient mortality better than anything else that we have. And so that's a question that is now embedded into some pathways, and it should spur the oncologist on to make that direct referral to palliative care. And sometimes you need that, I think. You need that sort of outside voice to say, what do you think you're doing? And to sort of press it. Practically speaking, based on the data that Dr. Boyd just presented, when I'm dealing with a relapse, I start talking about palliative care. We made a concerted effort, though, to rebrand it. So based on the experience at Anderson, we are calling our program a supportive care program rather than palliative care, which in colleagues, and I think Dr. Boyd would agree, we still have colleagues who think of palliative care as hospice. They'll have to expect patients not to think of it as hospice, right? So we're calling it a supportive care program, which I think is much more, it's much less threatening to patients. But I'm starting to do that now for people who are either diagnosed with stage 4 gynecologic cancers, and then I'm doing it for people at the point of their recurrence.
Okay. And how do you think, one more question on this, how do you think we do in terms of training the next generation of doctors in this? You both are in academic institutions, I believe, where you have, fellows and doctors that you're training. How do you teach them to have these conversations?
That's a great question, Joni. I think we used to assume that there were some people who were just kind of gifted at this and other people who were not so much, and you just kind of got what you got. And we've realized there's a whole area of research on this. You can train people to be empathetic. You can train people to listen better and to be more engaged. And so we have specific didactics for our fellows to make sure to learn how to break bad news. We actually work with our palliative team specialists. Like, how do you break bad news? How do you deliver that? And then, I will have my fellows come with me for these conversations, and they'll watch how I do it. And then in the right situations, I'll watch them do it. And so we make sure that they're learning appropriately how to do this. It's such an important part of the job. It's just as important as being surgically proficient and knowing your chemotherapy regimens, right? Because this is really where the rubber meets the road from the standpoint of engaging with your patients.
Right. I would agree with Dr. Boyd on that. The way I learned to do it, and what I tell our fellows is see how each attending does it. Take what you think it was done well, and then remember what wasn't done well and forge your way through. But more in terms of practical matters, we, like Dr. Boyd has said, we have formal didactics along with palliative care, as well as an exposure into a hospice program. And it's been, instead of thinking of palliative care as a separate service, what we've done, and I think they do it at NYU as well, palliative care is embedded in the cancer center now. So they are often there. They're seeing patients at the same time we are, and they're immediately available for consult when necessary. And our fellows get exposure to them as partners rather than consultants.
Yeah, and that's fantastic. And here in Alaska, we're really fortunate to have a palliative care doctor on our staff in our small clinic, and are able to, introduce supportive care. I agree that rebranding is really helpful with that, very, very early on in the process as a form of enhancing quality of life through the treatment. So Dr. Dizon, in terms of screening patients for sexual dysfunction and sexual health, how often, at what point do you do that? And how do you think we do as a community, a medical community, at actually talking about sex with our patients?
Well, here's the really interesting thing about it. It's a very common symptom that happens, especially in what we do in gynecologic malignancies. However, to have the symptom raised to the level that it's distressing doesn't happen frequently. So there's a lot of people who have issues, but they can manage that. And what was so fascinating is that, when I started doing this field, I tracked people for sexual dysfunction, and I also measured quality of life. And what was interesting is that sexual dysfunction might be present, but people were doing great. So quality of life was intact, even as sexual dysfunction was present. So it all is about distress. So in terms of screening for that subgroup of people whose sexual lives have been disrupted and it's problematic, is where we need to come in and not assume, right, that everyone might have some sexual dysfunction, but they're really okay. That's the assumption I think most of us in our community make, that we think, you're cured or you're in remission from your cancer. That takes precedence over everything. You should be lucky because you're alive. You should feel grateful. And you shouldn't worry about this other small stuff. That is toxic positivity. And that's what our patients oftentimes will have to deal with. Sort of saying, well, it hurts when I have sex. Don't worry about it. Can you just enjoy the fact that you're alive? So when I go around talking about it, it's to prevent us from saying that, because I still think, and we did a survey of gynecologic oncologists way back when. It's not that our community isn't trained or ready to discuss it, but practically speaking, we are talking about, are you in remission or has it come back? Do I need treatment? Do I not need treatment? Do I need a CA-125 or should I forego it? When people see us face to face, right, they want to know about their cancer. It's when they walk out the door that they realize there are all these things that they didn't have a chance to talk about. So the bottom line is it does behoove us to ask that one simple question when we meet people. So, you know, when we're meeting them for the first time, some people when you're diagnosed with endometrial cancer, you know, they had some sexual issues at the time of their diagnosis. Is that something that happened to you? And if you just open the door, when people are ready, they're going to walk through it. So that's the big message I'm telling my group. What's more important is that if a patient, which rarely happens, if the patient volunteers that sexual health is problematic, the worst thing we can do is turn it into something positive, like your cancer is great, you should be fine. The other thing you shouldn't do is to say, well, that's not my field, and just close the door on it. So I'm all about just making sure people have a resource, whether that's online, you know, a pamphlet, a book that they can look at, but hopefully we can get them to someone else, because we shouldn't be the ones to do sexual health counseling with everything else that especially gynecologic oncologists have to do. But we have the responsibility to look at it and to point people somewhere where they can get help.
So getting into a little bit more of the specifics with that, oftentimes as gynecologic oncologists or oncologists, we see a patient who, one of our patients who may have come from radiation oncology, have had radiation, and they'll come to me and they'll say that they've been given a set of vaginal dilators, which we heard about from BJ's talk, Dr. Rimel's talk. Question arises, what do you think about, is there a benefit to adding a vibrator to the dilator for women? And is that a study?
You know, I'll tell you one of the most fascinating things I've learned by looking at or helping women with all sorts of cancers with sexual health. The group of people who become anorgasmic after treatment for cancer are those women treated for breast cancer. It's fascinating to me. But women treated for cervix, anal, colorectal, endometrial, they tend to have orgasmic function intact. Now, having said that, remember, the dilator isn't a sex toy, right? The dilator is a medical tool to help with the vaginal spasm. Sometimes I will tell patients you can incorporate it into sexual play to make it seem less medical, where, you know, if you find that you're able to tolerate a dilator of a certain length, you can actually bring that into the bedroom as preparation for a partner who is going to penetrate, because that dilator can then pave the proverbial way to comfort for a woman, you know. But the vibrator serves an entirely different function. Hopefully it's to stimulate neural excitement back, you know. Some women have vaginal orgasms. Some women have, you know, clitoral orgasms. So it's very different, you know, and trying to sort of tease out what arousal was like and sensations were like, understanding that the chemotherapy that you just went through, the radiation therapy you just went through might actually change those thresholds. I do encourage vibrators, toys to come in, because it's all about re-exploring what is oftentimes a new sexual norm.
Excellent. And you mentioned this one last question where you mentioned aqueous lidocaine. Is that what's that's something that you prescribe? There's a question about how you get access to that formulation.
Yeah, so I will tell you, it's hit or miss whether insurance covers it. Just like for men, just FYI, you know, there's oftentimes a sense that men have more choices when it comes to helping their performance with the PDE5 inhibitors. Those are often not covered by insurance. For all practical purposes, men don't have free access to these drugs. The same thing is with aqueous lidocaine. Some insurances will cover it, some will not. But it is something that I prescribe all the time. The thing is, anyone who's having pain with penetration, that, in my opinion, is the indication for a pelvic examination. Because you want to see if it's limited to the vestibule or if it extends into the vagina. Because the Getch study in breast cancer, no one had a good effect if there was also vaginismus in play. But for women whose pain is really centered at the opening of the vagina, it's 4% aqueous lidocaine. And that's how you actually prescribe it. It's a liquid, not a gel, not a cream. It's a liquid formulation so that you can saturate a cotton swab and you can place it on the vestibule for 3 minutes before planned penetration. What I will tell women is not to have their partner do it on them, because typically what happens, the partner sort of paints the whole area and numbs the clitoris, which completely defeats the purpose.
Of course. Thank you so much. Yes, thank you so much. It's a rather wide sweeping range of topics that we're navigating between. As we close, since this is the end of our panels, I just wanted to say a patient, a participant mentioned that the language that we use, this is back to you, Dr. Boyd, the language that we use to talk about a disease that's not curable, but is treatable, and how we balance as providers, how we balance the information that, yes, this is likely the thing that will take your life, but yes, there are reasons to treat it, and there's hope in that treatment. Now that can be a very, very difficult way to figure out how to communicate, both reality and hope at the same time. And so, do you have anything? I don't know. I just wanted to open that up to see if you have anything last words you wanted to share on sort of how you approach that challenge yourself, Leslie.
Yeah, I think that's always really challenging for me as a clinician. First and foremost, I think it's my job to be as honest as possible, right? So even in the face of bad news, I mean, it's my job. If it's bad news, I have to deliver it. But we've all seen remarkably surprising outcomes, right? No matter what the diagnosis. So I think there's always hope that should be imparted, right? Because we never know really where the journey is going to end for any particular person. So that, and we also have the perspective that the patient doesn't have, right? So for each individual patient, this is their, hopefully the only time that they're dealing with cancer. But for us, we've had many women on this journey. So giving them a sense, some of our perspective, I think is also really important.
Well, thank you both so much for participating and sharing your expertise.